Okay, gang, we're gonna pick up where we left off. We're doing step 6, wide QRS for our 12 lead EKG interpretation. So, Hemiblocks. I know I've talked about it quite a bit already, so we'll just kind of dive right in. We're talking about either the anterior or posterior fascicles being blocked, so you have a left anterior hemiblock or a left posterior hemiblock. Because the left anterior is bundled up rather closely together, it makes it a little bit easier to break down, as opposed to the left posterior, which is not really organized at all, but is more of loosely dispersed. But again, posterior, anterior. All right, how do you find it? What are your official rules? I've gone over it a few times. Here we are. So left axis deviation has to be your first clue, and it's why it's one of the early steps and why I've put so much time into it. It's finally paying off. And what you're looking for is any time you have a left axis deviation that is -30 to -90, you really need to ask yourself if this is going on and if you should dive in and look. And you should. The official rules beyond that is that you have a either QR complex or an R wave in lead 1, or that there's an RS complex in lead 3, and probably 2 and AVF. That's the official rules if you want to be a real stickler for things, but that's also tough to keep track of. It's a little bit jumbly. So your shortcut is this way. And that's more of what I went over with in your right bundle branch block section when we had that beforehand. And so we still use our rule, -30 to -90. And then we cheat, and we only look at leads 1, AVF, and lead 2. And what we're looking at is positive in lead 1, negative in AVF and 2. And by that I mean your QRS has either a positive deflection or a negative deflection. By the way, if your QRS winds up having a loop-to-loop in it, I don't know what that problem is. That's way too complicated. Yes, that was a joke. If these criteria are met, though, you have a left anterior hemiblock. And it only took a minute. Like, the harder part's figuring out your mean QRS, let's be honest. For those that like a picture, here's a great picture. Up, down, down. Left, right, AB start, for anyone else that knows that little shortcut as well. So, 286. Let's take a look at this and we'll practice it. So, we'll do everything the same way we have been before. And I'll actually plug in our 6 here as well, where we've got rate of 90 or sinus rhythm. I will tell you that we are positive and negative in AVF, which doesn't surprise you, that our most isoelectric. So we'll do positive, negative, and ISO is going to be lead 2. And so that leaves us with a mean QRS of -30 degrees. And so that makes us think about left anterior hemiblock, which we will dig into in just a moment. But we always follow the same process, otherwise we're going to get ourselves in trouble. And for step number 4, we have no deltas. For step number 5, we're looking for enlargement. And so we look at those P waves here, P waves here. Look for our R to S ratio, and we'll count up our, number of boxes for left ventricular hypertrophy. And I will let you know right now that V1 has the biphasic P waves. And so we have left atrial enlargement. And we don't really meet any of the other criteria, so we don't have either of those. Step number 6, do we have a wide QRS? And the answer is no, we do not. But we have to come back to this because we did mention it. And rather than use that yellow that I had before, I'm actually going to use an orange. Hopefully that'll show up a bit better. And so we're going to look for left anterior hemiblock. And we're going to look in lead 1, lead 2, and AVF. And what we're looking for is if we want to see positive, negative, negative. And we are indeed positive. We are indeed negative, and most definitely negative. So we have met our criteria, and we are negative 30 to negative 90. So we most definitely have that. So our final diagnosis will be sinus rhythm with left anterior hemiblock. All right. The reason we do this here in all of this section, though, I wanted to point out that we do not have a wide QRS. Yet we're dealing with a hemiblock. How does that happen? How is that possible? Well, because of the size of the left ventricle, that's one of the reasons why the left bundle branch splits in two parts, is to get that signal all the way around in a quick and orderly fashion. Even without your left anterior fascicle, your left posterior fascicle can still spread that information well enough that it's conducted in a rapid manner and doesn't actually widen out your QRS. And that's why it's important to grab that mean to then look for something like this. And it's really important for, our friends down in cath lab, and they've talked about this before, is that, if they know their patient has, Hemiblocks or things along that nature, and they're going to be rooting around in there, they'll be more proactive about putting pads on them during the procedure, as opposed to a patient who has a nice clean cardiac history. So Hemiblocks are important. They're a good thing to find and be knowledgeable of. Posterior Hemiblocks. Physiologically, they're just more difficult to block because they're not organized. There's, there's a lot more real estate to take out, so to speak. In order to truly knock out the whole fascicle without just severing it completely or severing it at the root, you need to have a pretty big lesion. They're rare and they're more difficult to diagnose. But what happens is, because it covers all that real estate, it is going to affect the depolarization of the inferior posterior left ventricle. And what that does is it actually causes a vector that is toward the right quadrant and a right axis deviation, which is kind of interesting. So let's look at the official rules. And this is probably one of the most complicated ones in terms of rules that we've come across so far, so I'll take a little bit of time to explain this. So first off, you want to be in the right quadrant. So if we talk about what we were doing before, you're going to be in this section over here. You're going to have a S wave in lead 1 and a Q wave in lead number 3. You also have to exclude right atrial enlargement or right ventricular hypertrophy, because both of those will cause right axis deviation as well. So you have to keep that in mind. So once that's been done, you're down to using something that we call S1 Q3 T3 pattern. And what that shorthand represents is S wave, lead 1, Q wave, lead 3, inverted T wave in lead 3 as well. What's really interesting about this is a pulmonary embolism can also cause this exact pattern. So sometimes when the docs, patients having difficulty breathing, they shoot a 12 lead and they're like, oh, I think they're having a PE, let's go get that CT. That's the information that they're looking at, is that special pattern. And again, of course, signs and symptoms. If we're also looking for a left posterior hemiblock, they should probably be having a pretty big MI or something of that nature that you want to keep in mind. Last part I do want to mention, the Q wave here is not, it's not pathological. All right. If you couldn't have guessed it already, this is going to be a left posterior hemiblock, but let's walk through and do everything, all right? So we've got 1, 2, 3, 4, 5, and we'll do part 6 over there. But we have a rate of 105. We're in sinus tach. Our mean QRS, well, I'm actually going to take a little extra time on this one because we don't have many of these, or haven't done many of these, is that we are negative in lead 1 and we're positive in AVF. So down and up is a right axis deviation. Which one's the most isoelectric? Well, I'm kind of leading towards lead 1 again. Yep, I'll go with lead 1. And so if lead 1 is isoelectric, that then makes the AVF the perpendicular. Since we're in the right axis deviation section, we're going to have a mean QRS of positive 90. So that's one of those first criteria that we need to keep in mind. Do I have any delta waves? I certainly do not. But what I do need is to rule out right atrial and right ventricular hypertrophy. So we do the same stuff that we have been. And we will go here, and we'll take a look over here. And it looks like I almost meet the criteria, but not quite. I do have a peaked P wave. And I'll... So that is P. Excuse me 1 second. So that P wave is peaked, but it is less than 2.5 millimeters. And so at that point, it does not meet the criteria for P pulmonale. It's not enough to say it's truly hypertrophy. However, we do have the biphasic wave in V1, and that first half of that P wave is a little bit peaked. So we have a probable right atrial enlargement. We have a definite left atrial enlargement. Do I have any of the other criteria for a left or a right ventricular hypertrophy? Well, we have a pretty deep S wave here. That's 5, 10, 15. And we will say that this one ends probably about here, actually, for my R wave. 5, 10, 15, 20, 25, 30. So I would say we have a left ventricular hypertrophy for sure. And remember, if we were just going for greater than 35 millimeters. And then for our right, we do not have an R to S ratio in V1 that makes that worthwhile at all. So I have left atrial and left ventricular enlargements for certain. The right atrial enlargement's a bit of a question mark. We asked the question number 6, do we have a wide QRS? And the answer is no, we do not. So we can avoid doing any of that kind of bundle branch related items. And keeping in mind that we had a positive 90 degrees, we don't even have to consider a left anterior hemiblock. So that just brings us to step number 7. Or not step number 7, but our final part is to look for a left posterior hemiblock. And again, what did we need for that? We're looking for that S1 Q3 T3 scenario to double check things. So in lead number 1, do I have a negative S wave? And I'll bring your picture back up here. Sorry. So, sorry. Posterior hemiblock. Apologies for skipping around there. So, we have an S wave in lead 1, Q wave in 3, inverted T in lead 3. So I do have an S wave here. In lead number 3, I do have a Q wave right there, and I have an inverted T wave. So if you look at the whole picture on that, we definitely meet that criteria. It's not a perfect example, but it really does meet what we need to strongly suspect that they have a left posterior hemiblock. If you add in the part where they have left atrial and left ventricular enlargement, it means that there's some physiologic changes in that heart as well that might help explain why this is occurring. All right, last little bit here. We'll walk through intraventricular conduction delay as the final portion of our step 6. So what is it? Well, your QRSs are greater than 12, but the patient does not meet the exact criteria for a right versus a left bundle branch block. And in most cases, it's an electrolyte issue. And in particular, we want to think about hyperkalemia first, just because it's deadly. And you may remember from school, peaked T waves if it's hyperkalemia, and inverted T waves if it's hypokalemia, stuff like that. This is that chance to really look in it and go, no, wait, this is some hard and fast stuff that you can use. So take a look at this one, 278. So we will approach as we always have. And we will say our rate is 90. We have sinus rhythm with the first degree AVB and bundle branch block. Our mean QRS, well, we were positive here, negative here, and I'd say our isoelectric is AVR by the looks of it. Yep, and so put all that together, who's perpendicular to you. I'll do a mean QRS, let's do ISO. Negative 60 degrees. And that's enough for you to start questioning if there's a left anterior hemiblock, correct? Okay, so left anterior hemiblocks in our mind, we'll come back to it. I do not have any delta waves. Do I have any enlargements or hypertrophy? And if we look at that, and then we look at this one here, we're going to do a handful of different things. We really don't quite meet the peaked criteria here because it's difficult to measure. And even though this, we'll ignore that one. Even though this looks biphasic, it's not really, because if you compare it to the next one here, and even if you look at the next lead down, it's pretty clean. So we're not going to have any atrial enlargement. Do I have ventricular enlargement or hypertrophy? Well, I don't meet my R to S ratio requirement here, so that's not a thing. And I could add these up to see if I meet the requirement I need here. 5, 10, 15, 20, 5, 7, so maybe about 27-ish. So I really don't have any ventricular enlargement either. So that brings us around to step number 6 with our wide QRS. And so we're going to look at the same things we have been. I'm actually going to switch to green for this. And so V6, lead 1, and V1. So let's block these off and take a good look at them. Well, in lead 1, I have my sloping S wave, and I have a nice sharp QRS, so that will give me a right. And over here I have a bit of a slope, and this is still sharp, so that's going to be a right bundle branch as well. But in my V1, I have a broad S wave, and I don't have the RS R prime pattern or anything that even resembles it at all. It's all negative. And so that makes me think left bundle branch. Other things we can do real quick, we can look into our left atrial hypertrophy. And what are we going to look for? Well, we're going to look for positive, negative, negative. And I meet that criteria, so it looks like yes to that part. So it looks like I have a left anterior hemiblock. It looks like I have a right bundle branch block and a left bundle branch block. It's a mix. If I had a true left and right bundle branch block, we'd be in a lot more trouble. And think back to the example we did earlier where we had a right bundle branch with a left anterior hemiblock. Their EKG still looked reasonably fine. I didn't have any of this confusing stuff going on with my V1. When you see something like this, it's really important to then take that time and go in and say, what else is going on? What are their symptoms? They're a little tachycardic. What do their labs say? And in this case, this is a hyperkalemic patient, and you should always look for something like that. So that's what that's example. And that's one of those things where you may see both things at once on an EKG, but it doesn't necessarily mean it's actually the case. So labs, symptomatics, always keep that in mind. And if you really want to take the extra time, you could say that, this first degree AVB may also be the same reason why you're seeing a bundle branch block. It's a intraventricular conduction delay, or maybe just an overall delay issue throughout the heart. All right, we'll pick up with ST and T waves in the next section.